hear me?
Yes, I can hear. I can hear you.
Okay, good. All right, so our first speaker today, well, before I introduce our first speaker, I wanted to say a few words about the Delaware Quality of Life Coalition. The Delaware Quality of Life Coalition is a nonprofit that is essentially the hospice and palliative care network organization for the state of Delaware. We're the current home for the DMOS program, and we put on an annual conference, which this is it, as well as an annual awards dinner for the hospice and palliative care community. And that is scheduled each fall. We offer both individual as well as organizational memberships. And for more information about the Delaware Quality of Life Coalition, you can visit the website, which is DQOLC.org, or ask any of us at any time. So we hope that you might get interested in joining the coalition. We have some interesting initiatives going, including some legislation to support the DMOS program, and we would welcome your participation and interest. Okay, so our first presenter is the Reverend Dr. Carol Boggerty. She's the Director of Pastoral Care and Chaplaincy Services at Bay Health. She's a board-certified chaplain and chaplain educator. She holds a master's degree in social work and a doctorate degree in sacred theology. She's also the CEO and founder of the Vines Community Project Incorporated, which is a coalition that oversees community development and recovery initiatives in Kent County. The Reverend Dr. Boggerty is pastor at the Well Church in Dover and will be officially consecrated a bishop in July of this year. She's going to speak, I hope, on the importance of the spiritual dimension of serious illness. Welcome, Bishop Boggerty. You get your.
Thank you, sir.
We're going to show you these initial slides that include financial disclosures before we get to Dr. Boggerty's presentation. You can see there it's accredited by MSD and the Delaware Quality of Life Coalition for 3 CE hours of credit. Thank you.
Yes, sir. Thank you. Good afternoon, everybody. Okay, so I'm a pastor, so we need people to talk back to us, you know. I can't pastor that kind of church, you know. But we're going to be talking back and forth to each other because I want that's the kind of presenter that I am. And two, as we go along, I want to make sure that, you know, most of what I'm saying is actually landing. So faith and trauma, addressing the barriers causing health. I'm going to do this too because my eyes didn't stay as cute as I did. So addressing the barriers causing health inequity in hospice and palliative care. So I'm so excited to be with you all today. I really, really love palliative care is it's my heartbeat. Terry has been my mentor ever since I expressed interest in being a part of the palliative care team. And that was as far back as when I was in CPE. So she became my internship that I did everything in my power to maintain. I think I stayed in palliative for probably 1.5 years. And I did a lot of critical care areas as well, but I stayed in palliative care with TLT, and it has just become one of my greater joys. Can you guys hear me well? Okay. So when we begin to talk about hospice care, palliative care, I don't have to tell you guys the definitions. You all already know what it is. Specific to palliative care, when people enter that chronic disease process, one of the things that, and I'm going to probably talk about her or reference her quite often, but one of the things that I always reference Terry about is she always made sure that I knew I wasn't just someone that they thought was a good idea to be on the team. She always made sure that it was very, very clear that pastoral care is not like this a la carte service that we just call you guys when it's a good idea to have a reverend or someone of spiritual strength come into the room. You are a part of the team. When she showed me the construct of how we constructed palliative care, even in our system, pastoral care was right there with everybody else, a critical part of the team. So that's going to be much of what I discuss as part of Faith and Trauma today. So who am I? I do have a whole pile of letters after my name. I don't know where they came from because I have no recall of any of it. However, I did have a lot of bills that reference that it did happen. I think one of which I'm still paying, but yes, it did happen. So I do think I'm a little bit qualified. I've had a little bit of experience with this. No, I don't have STDs. I just, I always make that joke. I would be the one to go get a degree that puts STD after my name. So that STD is sacred theology. I always make that joke. So I know it's a corny joke. Spiritually healing, inner emotion focused therapy. It's a therapeutic approach to heal soul injury when trauma collides with faith. When you go before your patients have not just had a health emergency. They are literally having a spiritual and a soul crisis. Their soul is in crisis. Their spirit has taken an injury based on the diagnosis, based on their physical health, based on how they mentally received the information that they got. They are in spiritual crisis. A trauma has happened to their souls, and they need more than physical care to be able to address that. So what is the challenge? The faith-filled trauma survivors create reasons to stay stuck, which fuels resistance to seeking therapy, but faith creates the space for healing release. Now notice, I want to be very, very clear. Though I'm a pastor, I'll make a lot of religious jokes. I hope you all are not like, you don't have thin skin. We all laugh at these things. It's how we get through our day. And I promise you, I mean no disrespect to any of it. But when we introduce atmospheres and environments for religion, we become isolating because a lot of times we can't serve a person's religion, right? So the first thing we have to do is understand what the chaplain serves. What's your spiritual and faith providers? What type of service do they provide? So let's talk today. Who is your chaplain? What does your chaplain do? Who's your chaplain? What do they do? Oh, me. What is your chaplain on your team? Good practice answer. Why? Why are we essential? What makes us essential? We look beyond the physical. Emotional and psychosocial state. Those are going to be very, very critical to how you see your chaplain. When we come into the room, we do not come into your room to that patient's room to just pray. How many of you used to call your chaplain just to pray? It's okay, right? Because they need prayer right now, right? And you needed to pass off to someone. So you call the chaplain so that this chaplain can come running in and provide these prayers. Well, the chaplain does far more than just pray. We do way more than pray. A lot of times when you all are seeing patients, particularly when we're talking about hospice, and especially when we're talking about palliative care, you're seeing people in the cycle of their disease where you really need to be thinking clinically in that moment. You really need to be focused clinically. You don't have time for the ancillary types of services that pastoral care can bring into that room. So when we come into the room, we don't come in with their faith practice, their religious practice per se, but we do come in to be a presence of faith, a presence of hope, and a presence of emotional stabilization is the word that I want to use. A lot of times people are crying, their family, they're confused. They just got this diagnosis. They don't know what to do with this diagnosis. Is my mother dying? You're saying palliative care. God forbid you say hospice care, right? Because that means they're dying tomorrow. That's usually the thought, right? That they're not going to make it home, that this person is leaving here. They don't really understand what this process is. You have time to explain the service, but you do not have time to be a demonstrator of it. You have to pass it off to someone. And guess who your partner will be? It's your chaplain. Faith-filled trauma survivors create reasons to stay stuck. You need somebody to come in and lift the burden of their reason, because as soon as they can reason enough with themselves on why they need to stay stuck in despair, why they need to be depressed, why they have lost all hope, they will begin to build up resistance to everything else. They will not hear that this chronic disease can be treated with medication. They will not hear the doctors say, you know, normally this disease process is a 2-year process. So they will not live the next 2 years with the greatest amount of quality that they can have. Why? Because when they were at the place of reason, nobody helped them to not build up resistance. So they feel resistance to seeking help, and bringing in faith allows them a portal for release. So reason, resistance, and release. Those are the 3 R partners when we talk about the collision of faith and trauma. We want to get people from reason to release as quickly as possible. As quickly as possible, right? For some, it will take longer than others, but you want to process your patient, your patient's family members. Sometimes your patient in the bed is not your patient. Well, for us, they're not our patient. Our patients become the family members. That patient lying in the bed, they may be intubated. They can't communicate with us, right? We can't process faith with them. We process their faith through their representation, which 9 times out of 10 is their familial community, which will be their family members, their friends, so on and so forth. Am I talking too fast? I have a habit of talking fast. You know, at my church, they put a timer in the back now so that I know to hurry it along. So the reason we have to fill the sacred space that faith-filled trauma survivors have between knowing that God or their higher power, however it is that they worship. I don't want you all to see God here and not think. Everybody does not believe in God, and it is okay with your chaplain. Can I tell you why? Because just as you are clinically trained to do what you do, so are we. We are trained, part of even my doctorate degree. Sacred theology made me learn everything about everybody. If it was out there, I'm sure we studied it. And if we didn't study it, somebody mentioned it, right? So are we. You want to get us in so that we can feel that sacred space for your patient, so that they can go from knowing to allowing. Remember what I said about resistance? You might know that you have hope. You may have all the information. The doctor may have given it. Your nursing staff, we have some incredible nurses right here in this room. I've heard them as they spoke through process to someone, and I still watched them leave the room. And when I remained, there was still so much resistance. They did an incredible job, but they didn't have time to walk the whole process through. That's why you need us in the room. So we fill that space of knowing and getting your patient to allowing hope, faith, their spirituality to be there and to be available to them, right? So most of us, because we know the dynamic of different faiths, we are able to remind people, hey, this is what your faith construct says about this. How can I help you and your family walk through this? The disjointed manner in which faith-filled trauma survivors deny themselves spiritual permission to not be okay. They do this by putting on a mask, right? So because they've gotten the information, they've processed information, they understand what it is that they've been told, they don't agree with what they've been told, they don't want this to be the plight for their life. They have this family, whether it's young children or whether it's a mother or father that's watching their adult child, or whether it's adult children that's now watching their parents. We have a habit of normalizing what's happening in the room with a mask. And guess what? The best medicine, laughter. We begin to take what is supposed to help us get through, and we use that in an improper manner. You know, we pervert it. We don't allow. Laughter is supposed to be comforting to us. Laughter is not supposed to keep us in a place of denial. So what happens sometimes in rooms is, as families begin to remember and to go through recall, they'll start to laugh and they'll start to have fun. Anything that they could do to avoid the moment and the reality of what is happening inside of that room. That's not processing faith. That's leading them to here. That's leading them to resistance. You don't want them to not be able to be themselves if that's the identity of the family. But when brokenness resides, is there a way, let's see. Yeah, see, I can't see it and neither can you. Can I collapse the screen on the side? Is there a way to do that? So that the full screen could, is it, what'd you say? Yeah. Thank you, sir. Thank you. Is that a little better? So now you guys can see all the words. Okay. So when brokenness takes residence in the heart of a faith-filled trauma survivor, it impedes the flow of healing in their lives. You don't want to give them time for it to take residence. So we start processing through what's happening with our trauma, with our faith-filled trauma survivors. We want to get in that room. We want to become their partner. What happens with the inequity here is the fact that most people get to resistance before they are ever offered pastoral care. They have been allowed too much time from the point of contact, whether it's in the emergency room, their doctor's office, their medical appointment, whatever that was. They've been given space from the point of contact up until this point of resistance. They've been given so much time before your chaplain or your spiritual support system is able to get to that room. It is the reason why I say it is inequity when we don't distribute your services accordingly. If your chaplain is a part of your care team, right? She said we were a critical component. I didn't mean to say she. What's your name? Miss Sarah said we're a critical part of your team. If you truly believe that, then the same way you introduce the medical services that are available at your facility, the same way you tell that family where the cafeteria is, where the gift shop is, where the smoking outside areas are, the same way we say, I hope y'all are not telling the people that, right? Okay. But the same way we tell them, you know, cafeteria and all those things, the chaplain should be a part of your conversation immediately. Here is what your conversation should not say. You should not say, would you like someone to visit with you to pray? Because that is how we are introduced. Oh my goodness. Did you? See, same tone and everything, I'm sure. See, good job. See, that's how we are introduced to your patients. In that moment, they are in crisis. They do not want to hear about prayer. In that moment, they don't even want to hear about their God or their higher power. They need someone to be able to connect to them in their spirit and in their soul. And because we know what we know about faith and about spirituality and the way different people practice, we know how to make those immediate connections. And it is not through us going in their room to just say a prayer. So make me a promise. I promise, Reverend. So we don't want to give time for brokenness to take residence. We have to get this process going a little bit sooner so that the faith-filled trauma survivor, the flow of their healing can begin. So when brokenness keeps faith-filled trauma survivors in a continuous loop of traumatized emotional state, the loop is filled by disengaged faith. We want to get in to help you get them back re-engaged with their faith. And here's what I'm going to tell you. The challenge with faith, and I wrote myself a note because I wanted to make sure I say this so much. I want to make sure that I said it in this environment. Faith is not false hope. I want to tell you all that. Us helping people to believe in something in a time of crisis, it is not providing people with a false hope, right? It is the vehicle that many of your patients will need to ride on their journey towards healing and acceptance. Faith is a vehicle for them. Their spirituality is a vehicle for them, and it can be a strong force to get your patient to a place of acceptance. I cannot tell you how many rooms I have been in where people will believe beyond what the doctor said, right? And it would be so frustrating to the staff. And the staff statement will tell me, well, Reverend, you just got to go handle it because that just doesn't make any sense to me, right? Well, guess why it didn't make sense to them? Anybody know? In some of those cases, why didn't it make sense to them? It's very simple. We don't practice the same. Yeah, we don't share the same faith. We don't believe the same way. Their faith construct says, I'm going to believe that I have hope beyond this current situation. And some people believe this. My faith construct believes this, that if I pray, even if I don't get healed here, that death is still a conduit for my healing because there's a place for me that's not here, right? I believe in heaven. So I believe that when I leave here, I'm going to go to heaven. At least that's my prayer. Me and Jesus have many conversations about it, right? So for me, my conduit to heaven may be death. Do I want to live longer? Absolutely, right? So for me to tell my doctor or for me to tell my nurse or my healthcare team that, hey, listen, I know you said I got 2 weeks, but I just believe just by my faith that I'll be here just a little bit longer. You are not allowing that person to rest in a false hope. Guess why you're not? Because you're still going to provide the solid clinical care that you've been providing all along. You're still going to give the information because that information is still going to inform that patient on what it is that they need to be working on, how the kind of care you're going to be providing them. You don't have to take a person's faith in order to get them to hear your the clinical care that you're providing for them. That's kind of hard in this environment. Do you guys agree? It's kind of hard. It's challenging, especially when you see someone and they're struggling in their processes. I want to make sure I stay on time. So I'm going to tell you, because of the last slide, this slide, I'm sorry, that we're on, I want to tell you my story because it's attached to Christiana Care. So back in 2013, my husband, he came here in critical care. He had kidney failure for 20 years at that point. And he had come to Christiana. And, you know, he was in your cardiac ICU and, you know, I was here and you guys, there's a church that's not far from here that they came, the pastors let me stay in this house. And so, because I was at the hotel and I was spending all this money in the hotel and the nurses and the doctors were like, you can't do this. My husband was very well known in Kent County and just everyone knew him. And when we got here, it was the same thing. And everyone was just so amazing and so supportive and so helpful. What people didn't know was my husband and I had already had a conversation about his end of life care. And his end of life care had to consist of his ability to fight as long as he could. Why did he have that? It was because he had already fought for 20 years. So he was informed by what he had already gone through that, you know, this is part of the process. We either bounce back or we don't, but you give me time to bounce back. And if I don't bounce back, I'm going to let you know. And he said, I promise you, I will not allow myself to sit here and to struggle long. He said, I promise. He said, but you got to let me fight, right? To your chaplain here, do you all remember Deacon Malcolm, Pat Malcolm? Okay. Pat Malcolm was my chaplain. Because she understood my faith process, She was the third chaplain actually that got to me. And by the time she got to me, she goes, I already know. So how do we process through this? I said, we let him fight. And when he cannot fight anymore, he won't, right? That simply meant nobody come and ask me again about changing his DNR status. Nobody come and ask me again about what type of care we're going to provide for him. Nobody come and ask, right? Because I too am what? Going through trauma, right? So it changed how care was provided equally between my husband and myself. Sometimes the inequities happen on how we distribute the service that we provide, right? They knew the other chaplains, okay, that didn't work. We need to get somebody that's more relatable to what's happening, right? She had stories of her family. We were able to relate. She was able to come in, get me on track, allow me to voice what it was that he wanted, what it was that he asked for. And that was the way his care played out. He literally passed away 2 days after that. Just 2 days. So he didn't even linger long, right? So timing even was a part of that process, knowing when they needed to get somebody in there to me. Okay. Disengaged faith is a surface faith that is disconnected from the healing power of God or your patient's higher power, or where it is that they are spiritual. Faith-filled trauma survivors need to be guided to a, listen, spiritually managed trauma recovery healing state. Spiritually managed, that's a mouthful. Spiritually managed trauma recovery state. They are already in a healthcare setting. They are already being managed clinically by your healthcare team. They need now to be spiritually managed to help them towards a recovery state. Reverend Miller, who is my staff chaplain, reminded me of this statement earlier today. What was the saying that you said? We were talking about a sick soul. Do you remember? No, she went to lunch and forgot. Listen, so the basic gist of our conversation, she was just saying that a person can be healed physically, and if their soul and spirit remains injured, they will never see full recovery. So you will see someone, we see it every single day. We will have some of our cancer patients who are literally in remission. They are coming in simply for their checkup, and they are still grieving as though they are in the cycle of the disease. And they are in and have been in remission for a long time. And what we have found, and many chaplains, and when we, many have done, there's soft studies that are out there. Most of the times when you talk to people and you find out why, it's because they had no access to faith support or spiritual services while they were going through their disease process. Isn't that something? So you want people to be able to engage in their faith. You don't want them to disengage from what it is they believe and who it is that they believe in. You want them to do that because that is going to help the spiritual management of their healing state. Spirituality belongs to all cultures. Everybody has a right to spirituality, whatever it is, and has both an individual and a cultural specific and within group interpretation. Spirituality is integrated into the individual's consciousness, emotions, and overall health and well-being. Clinical healing, that's when using medically proven applied theories to provide curative, palliative, or hospice care for patients who present these symptoms. As healthcare providers, do you think this is somewhat true? Does that kind of ring true for everybody? Well, you see how you have a definition? Guess what happens? We have one too. Using spiritual tools like prayer and scriptural affirmations to terminate the destructive behaviors that serve to maintain escape and denial while implementing behaviors that promote healing. We want to get people to a place where they are able to heal whatever healing looks like for them. For some of your patients, they will never physically be healed. But if we can get into this process and this cycle with them, we can help them mentally get to a place where they of acceptance. And that alone is so healing for many of our patients. when they can get to a place of acceptance and they know that this is the disease process, this is what's going to happen with my life, and I am at peace because my care plan is in place, my advanced care directive, yay, Carol. Y'all heard that? Y'all heard that? I know you all like that when I plug that one in there. 5 wishes are in place. Nobody has to guess what's going on with my life. And now I can go through the rest of the cycle of this disease with my spirit and my soul intact. Embedding spiritual sensitivity into specified clinical practice that creates the grace and the space for faith-filled trauma survivors as they are healing. That's one of the things that I have to say. Again, I have to mention her. TLT has that to a science. She immediately goes into a room and can immediately tell, you just need to come up and hang out. Like, they're not going to need much. Really nice patient, really nice family member. They just need some extra support. Just check in with them. And then we'll get the call that will say, no, we need everything. I need to assess them, find out where they are spiritually, what kind of supports do we put in place? Maybe they need to be on a rotation for spiritual care and support. You know, we'll have a split family because some of our families don't even believe the same. She'll say, you need the priest and the reverend. And don't call the Lutheran reverend. It needs to be a Methodist reverend. And I'm like, reverends are reverends. No, they're not in this room. The Methodist reverend is the Methodist reverend, Carol. So you have to be able to provide that space and give people the grace of at least trying. This morning, I had the privilege and the honor of training our chaplains from Dover Air Force Base. They came over so that we can partner with pastoral care. Because, you know, just the credentialing and all of that right now, we just really needed some credentialed support. And when they came over and we just began to talk about the way we provide space for our veterans and space for our active duty military and space for them to tell us, you know what, I really appreciate the care that you provided, but I really would like a VA chaplain, or I really would like. That is the best thing that could happen to your patient or for your patient. Know why? Because we will kick into gear and find you the chaplain team member that's going to make your work a little bit easier. Because you don't need me in the room if I'm not what that patient needs spiritually, right? You need what they're asking for. And it was such a great conversation for us to have the ability to be able to do that for our veterans and our active duty military. Faith-filled trauma survivors are being challenged in their understanding of where is my God? Where is my higher power when I'm going through this trauma? And we come in with exactly what we've been talking about all along, and we define, what does bringing you out of this trauma mean? Right? Because for many people, the truth is it's going to be death, or it's going to be a different type of quality in their life. They may not go back home to the same type of life that they had before here. So in my construct, I want to give you this. And again, if you don't, we're not all Christians, but this scripture, these passages of text, if anybody wants to read it, I encourage you to read it, because it literally demonstrates someone and the cycle of faith-filled trauma. So here it's about David, King David, right? So David is going through this trauma of, oh, I believe in you, but where are you? My enemies are doing this to me. Everybody, they're fighting against me. I'm hiding in a cave, but I believe you. I trust you. I know what you promised me, but I'm on the run, and this man just threw a javelin at me, and now I'm sick, and I'm cold, and it's raining, but I trust you. I so trust you, and I know you're going to bring me. That is the cycle that happens in the minds of our patients who are going through their chronic disease process. They may be on hospice, or they may be coming to the palliative care clinic, but that is their cycle. In between their visits, they're not thinking about what's happening to them. They're not thinking about the diminishing of what's happening in their body. And as soon as they know they have an appointment with you, it all rings true to them that this is real. This is real. And I wanted to share that with you because you literally can see this man go up and down and up and down and up and down. And he never stays high long. He has more language in the valleys of what he's saying than he has when he's up on the hills. So that means by the time they get to you, It's their valley. And you don't always have the time because you have probably 50 other patients to get to, but you don't always have the time to walk them through the totality of that valley in that moment. You need to call your partner your chaplain. The movement toward healing when trauma collides with faith is an uphill battle. Just like I said, it's an uphill battle. And I'm gonna share this with you. You all are gonna, but I thought it was very profound in my thinking. It was one of the moments that I thought I was smart. When you're with your patients and you look up at the EKG or you look at the heart monitors, what makes you feel best when the lines are going how? Up and down, up and down, up and down, right? Because you know that heart is beating the way it's supposed to beat, right? When are you not your happiest? When that line levels out, right? We're not looking for a balance with our patients. Because if the line goes like this, we're in trouble, right? Peaks and valleys for our patients, we want to make sure that we can just meet their needs when they're going through their peaks and they're going through their valleys. Sometimes when things level out and you see that level out, we can go back to an earlier slide that family or that patient has been able to successfully put this mask on and they are really in a place of denial. I should preach that one Sunday. These are the cogs: faith, trauma, and holistic health. Holistic health is gonna take care of the whole patient. Faith and trauma, if you look at those cogs, how those cogs are situated, they can bang into each other if they're not positioned properly. If their timing is off at any point, they will block each other from flowing. You need to always be able to make sure that the cogs of faith and trauma are able to work seamlessly together. You are the patient's focus point of trauma. You are the only ones that can treat them medically and clinically. We absolutely cannot, but we can provide them with that faith-filled environment that will keep the cogs turning so that their holistic health process is beneficial to their life. That's the end of my slides. That is my contact information. Should you ever need me for anything, I am really, really passionate about the partnership between pastoral care and your clinical care team. I just think that, you know, a lot, and COVID, I have to tell you, taught me that. I have my references and everything here too. I want you all to know I did study a little for this. But COVID really, really reminded me how important it is for the teams to work together. Because during that time, our patients did not have access to their families. And guess who became their family? And guess who became their family's primary liaison? So chaplains, at least at our facility, we were running through the hospital with iPads and trying to get people virtual visits. And, you know, I literally had cell phones to patients' ears because loved ones who had been married, I had one family, one husband and wife, they had been married 71 years and all she wanted to do was hear his last breaths. That's all she wanted to do. So we put the phone, we made sure that there was a phone there so that she could hear him as he, you know, as he was leaving. And we wrapped his last EKG read, we wrapped it and we gave that to her so that she could at least have his final heartbeat, because that was so important to her that she was there for that. You would not have had time to do that, what the chaplain did. So I really want you all to really remember us and keep us in your thoughts when you are caring for patients that are in trauma who may be filled with faith or lack thereof. Thank you. Yes.
Can you share with us some phrases that nursing can use to introduce chaplaincy services in a better way than just to
Have somebody pray with you.
Well, the first thing I would ask.
Yeah, the question for the people online is, what are some phrases or introductions that the clinical team could use to assess the usefulness of getting pastoral care involved.
So the first thing that I would tell you is that make that chaplain part of your presentation when you're presenting all the other services. So you really don't even have to say much about us other than when you say you're going to be treated by the respiratory therapist, by food and nutrition is going to come and visit you, and you're also going to get a visit from the chaplain. So in our facility, everybody gets touched. Everybody gets touched. And that's because we're not just coming touting religion, it's a service. So everybody in our facility gets touched. So the only thing that most people, what we're trying to do now to kind of normalize it is we make sure we ask people what their faith is. Do you have a faith? And if you do, what is your faith? So that really is more our introduction to the chaplain, because that's all the information I need, because I'm going to see them anyway, right? If your facility does not do that often, then I would ask people simply, how can we help meet your spiritual needs while you are a part of our facility or while we serve you? Because then they can tell you what it is that they need.
Reverend Carroll, you certainly showed us how important addressing the spiritual dimension to serious illness is. But on a lot of teams, the chaplain is a very limited resource. And so a lot of times the approach is to have a clinical team do a screening process and identifying what spiritual needs a person might have before connecting them to the chaplain. Are you saying you should go beyond that and make it just a regular part of every care interaction?
Mm-hmm. So for me, the culture of our day is moving that way. Most people are practicing some type of spiritual practice at home. And I notice I said spiritual, I didn't say religious. Most people are practicing some type of spirituality outside of the work environment or, in their homes. So yes, I would absolutely say that our teams need to start building on that. I think clinically you guys do a great job, but when somebody comes in and they're in crisis, we are the last service you think about. But we are the first service that family is thinking about. Those family members are outside in that waiting area, wanting somebody to come and pray with them, wanting somebody to be with them and helping them emotionally. But while you're inside treating them clinically, we can be a part of that support. We also do the assessment. So we do our own spiritual care assessment and we provide you with the results. So you also know what our assessment look like. And sometimes the clinicians don't always diagnose right, Dr. Goodall. I'm sorry, sir. I just wanted to say it, sir. I had to get it out.
Keegan, are there any questions on the chat? So I have a question. The clinical team is not always successful at healing from a physical standpoint.
Yes,
so I imagine there are times when you can't get to spiritual healing.
mm-hmm.
And what does that look like and what do you do in those situations?
So in those situations, we just simply offer hope. Because some people are not going to get to a place of acceptance. They're not going to get to a place of spirituality or a place of faith. So we simply offer presence and we simply offer hope, right? Because some people will still have the conversation about hope, right? What does that hope sound like? I wish I didn't have to go through this. Or I wish this is going to get better. I wish, right? I hope that doesn't really happen. I hope that it doesn't come true. And we support that. I hope that you get what you're asking for. I hope that you feel better too. So we offer presence and we offer hope.
Thank you very much.
You're welcome.
Any other questions before we move on? Thank you very much. That was wonderful.
You, sir.
Okay, I think we will move on to our second presentation. Okay, let's take a 10-minute break. For those of you online, we're going to take a 10-minute break. Come back to the second link. Thank you.